Yes.
Hi everyone, I'm Suchit Amatya. I'm one of the HIEM doctors. Today I'm going to present on anal pain and rectal bleeding. As Boone suggested, some broad headings. I try to include every broad headings, but let's see how it goes. Epidemiology. Rectal bleeding is most common symptoms in adult of all ages. The 1 year prevalence in adult is about 10% in UK, and as many as 1 in 5 primary care patients will report rectal bleeding in the previous year. This I have I've got it from one of the journal that I was going through while preparing this presentation, basically. Before starting, we as ED doctors have seen so many patients with rectal bleeding. I'd like to ask, some other my colleagues, what are them, what type of what type of rectal bleeding they have seen in the ED. Sikandar, have you seen any rectal bleeding in?
Yeah, I have seen like around like 10 cases in the ED.
Yeah. What are the differences then?
So I have seen like a 16 years girl. She is presented with rectal bleeding 2 times in DRI. So
yeah.
basically she's complaining, but at the end I found nothing. So the 2 times I've seen that the same patient sent home with with the senior doctors.
Okay. How about Prajwal? I'm just going through this, talking to those who I can see in screen right now. It's nothing like,
Right.
I'm so just focusing on him too. That
broadly we can divide into upper GI bleeding and lower GI bleeding. So I think we're more focusing on the lower GI bleed.
Yeah.
So it could be because of like in elderly patient, it could be like because of prostate cancer as well, and also like hemorrhoids, stuff like that. That's the thing I could recall.
Prostate cancer probably very late stages. We should not put the first cause of prostate cancer. You can put in miscellaneous in the exam, but prostate cancer has to erode the rectum, which is probably people will be dead before doing that, but it does happen.
As Prajwal correctly said, one of the cause of rectal bleeding is hemorrhage. There are so many other causes of rectal bleeding. There are anal fissure, rectal prolapse, diverticular disease, colonic polyps, infectious gastroenteritis, ulcers, cancer, STDs, and also some traumas. So let's quickly let's go to anatomy quickly. Rectum and anal canal has 2 parts. Rectum and anorectal canal has 2 parts. Rectum and anal canal. Rectum begins as a continuation of sigmoid colon. It begins at rectosigmoid junction at the 3rd sacral vertebra. Rectum measures about 12 to 15 centimeter in length. Following rectum, anal canal begins. It is 4 centimeter in length. Anal canal is supported by 3 main structures. They are levator ani, mainly puborectalis muscle, external anal sphincter, and internal anal sphincter. Interior of anal canal contains, vertical fold of mucosal membrane that you can see in the screen as well. These are called anal columns. At the end of at the lower end of anal columns, 2 anal columns joined with transverse fold of mucous membrane. These are called anal valves. The importance anal valve and all the anal valves join together to form a line which is known as pectinate line. Pectinate line is very important here because it separates ectoderm and endoderm, and it all we also classify so many anorectal problems in respect to pectinate line. And pectinate, above the pectinate line, it is lined by columnar epithelium, and below the pectinate line, it is stratified squamous epithelium. After that, we'll go a few of the causes of rectal bleeding that because I've prepared this presentation mainly based on HIEM learning. So I've gone through HIEM learning and Rosen. So I'll be including some of the diseases. They are included there. It is, well, the first one is hemorrhoids. Hemorrhoids is basically enlarged vascular cushion in anal canal. Anal canal normally contains 3 vascular cushions. They are 3 fibrovascular cushions that they are at 3 o'clock position, 7 o'clock position, and 11 o'clock position. Due to repeated passing of hard stool and repeated straining, the protective mechanism or the supportive structure for this vascular cushions get damage, and once these vascular cushions are filled with blood, they may get engorged, and they may get engorged, causing the features of hemorrhoid. In a patient with hemorrhoids, the patient usually comes with painless bleeding until and unless it is thrombosed. And the patient complains bleeding is bright red in color, and it is included, it is associated with stool, and the patient also complains of bleeding in the pan as well. And depending upon the hemorrhoids can be classified based on pectinate line into 2 major parts, two types. They are internal hemorrhoids and external hemorrhoids. The hemorrhoids that lies above the pectinate line are called internal hemorrhoids, and hemorrhoids that lies below the pectinate line are called external hemorrhoids. And based on the severity, or based on prolapse and reduction, it can be also classified into 4 types. The first one does not prolapse at all. The second one prolapse on defecation, but it goes spontaneously to a normal position. Third one is third degree hemorrhage. It prolapses spontaneously or during defecation, but the patient is able to manage, or the clinician can able to manipulate and put the hemorrhoids in its normal position. Fourth one is permanent one, and it is irreducible at. And following this, I'll go to the treatment. Depending upon reducibility, the treatment can be broadly divided into 2 parts. For reducible, we can prescribe patient with wash regimen, and for a non-reducible one, it is a surgical referral should be made. Wash regimen, it includes it is a combination of 4 things. W stands for hot water. Hot water tends to decrease the anal pressure and also relaxes the muscle, that decrease the muscle pain, and also that reduces the pain. If for analgesics, for the pain, if the patient has any sort of pain, it will relieve the pain. As for stool softeners, it could be debulking agents or osmotic agents that we can prescribe to the patient. And it stands for high fiber dyes. That is also reduces the bulk of the stool, that relieves the patient to pass softer stool and decrease the pain. Okay. Before this, there one of the cause of surgical referral is 4th degree prolapse. Can you tell some other cause where rectal prolapse or where hemorrhoids, prolapse hemorrhoid needs to be referred to surgeons? Saurabh?
I'm not really sure, but maybe with infection or continuous bleeding, or if the patient is on anticoagulants.
Yeah. How about Prajwal? Rajal Adhikari, are you there?
Yes. I'm not too sure about this.
Okay, no, fine. So these are the points that we need to refer, the cases we need to refer to the surgeons. These are, as Saurabh said, profuse hemorrhoidal bleeding, and in case of thromboid hemorrhage, and in case of necrotic external hemorrhoid and 4th degree that I have mentioned earlier, and in cases of suspected malignancy, we have to refer this patient to the surgeons. Any question up to here? Then I'll proceed to next topic.
Before you proceed,
Can I ask
Yeah.
you one?
can you hear me?
What does it mean, like thrombosed hemorrhoid?
Thrombosed hemorrhage means sometimes the bleeding inside the hemorrhoid can be thrombosed, that can cause thrombosed hemorrhage. Basically, we tend to find out twisted hemorrhage, that is purplish in color. But sometimes we can also find hard mass, that the blood inside the hemorrhage can be thrombosed.
Thrombosed hemorrhages, I mean, sometimes there are prolapse because the external anal sphincter cause a pressure, blood doesn't return, and the blood stays. Stasis called thrombosis. But sometimes they are internalized. If you do PR examination, you feel little like, tense set of swelling into the areas 7-11 or what are the 7-11 o'clock position? So you can see that tense swelling on the PR examination. They're very painful, so by the nature of the pain and thrombosis, you admit them. And the surgeon tend to operate on them because the theory they present, it might well thrombosis might extend and cause necrosis of the lower GI tract.
Next one, I'd like to proceed on anal fissure. Anal fissure is superficial tear in anal mucosa. Again, here the mechanism is same as in prolapse hemorrhoids. They are recurrent passes of hard stool through anus causes tear in a superficial layer of the anodome that can produce anal fissure. Anal fissure in a patient can be in different positions. They can be in anterior position, they can be in posterior position. Among these, posterior one is the most common one because muscle fiber encircling the anus are weakest in the posterior one. So posterior one is most common one. However, it can be anterior as well, which is more common in female. Apart from anterior and posterior, if the fissure are present in any other portion, these are always associated with some other systemic illness, like in this figure. It is we have few points like Crohn's disease, tuberculosis, HIV, leukemia, anal neoplasm. So we have to be careful regarding the position of anal fissures as well. And anterior and posterior anal fissures are also called as typical, and the rest are called atypical anal fissures.
Can I ask you one more thing, Suchit?
Yes.
So as you said, like anal fissure is subcutaneous, and now you're talking about like a posterior anal muscles. So is it like a fissure is?
No, I'm talking about the superficial mucosa, not the muscle.
You are talking superficial. Okay, fine. Yeah.
I think that because there's a pain and the sphincter get into spasm.
Yeah.
And cause pain, constipation, and everything. And yeah, so that's why the anal sphincter is secondarily involved, not the primarily, because the fissure is painful and anal sphincter gets spasm and causes problem.
Yeah, thank you.
Yeah, as Dr. J correctly mentioned, that the patient with anal fissure presented with sudden onset of excruciating or a shearing type of pain, which is associated with bloods. Bloods here is bright red, but it is minimal, and the patient usually complains of pain, blood while wiping out their back. following defecation. Following this shearing type of pain, the patient usually complains of burning sensation around the anal region, which is due to spasm of internal anal sphincter, following which the patient, the successive defecations are excruciating because of reflex spasm of external anal sphincter. And again, the management of anal fissure are broadly divided into acute anal fissure and chronic anal fissure. Acute anal fissure again follows the WASH regimen. WASH regimen is the same regimen that I have mentioned in hemorrhage as well. It is hot water, analgesic, stool softener, and high fiber diet. And chronic anal fissure can be treated with nitroglycerin. These are vasodilators. And with use of nitroglycerin, the patient often complains of headache because of vasodilatation. And another one is nifedipine, that comes in combination with lidocaine. These acts by blocking the calcium channel, which relaxes the muscle and relieves the pain. But most of the irrespective of acute anal fissure usually tend to heal in 2 to 4 weeks basically, and chronic anal fissure, if this is ongoing problem, then we need to refer this patient to the colorectal surgeon for the definitive management, who would give botulinum toxin injection, and also can go for anal dilatation and sphincterectomy. If the anal fissure is not properly treated, it can proceed into the triad that is known as the classic fissure triad. Is anyone aware of fissure triad? No. Fissure triad includes enlarged anal papilla, sentinel pile, and deep fissure. And these three makes a triad that is known as fissure triad. Next one I'd like to proceed. One is anorectal abscess. Anorectal abscess is basically produced due to in the crypts of anus there are mucous gland. Occlusion of this gland can produce abscess in the different part of anorectal region. As even in this figure, we can clearly see that this rectal abscess, intersphincteric abscess, perianal abscess, and supralevator abscess. And the patient usually the most important causative agents for anorectal abscess are Staphylococcus aureus, E. coli, Streptococcus, Proteus, and bacteroids. The patient complains with pain. The patient complains of pain with indurated mass or swelling in the different parts of anorectal region. Again, the patient may complain of discharge, post-discharge, or sometimes bleeding per annum, and also complaints of fever. However, this presentation can vary with the position of the abscess. I've included this table from the Rosens, and it has listed the situation and features and treatment for different anal sphincter. First one is perianal sphincter. Perianal sphincter are perianal abscess. Perianal abscess, the patient with perianal abscess usually present with mass in the perianal region or at the anal verge. And anal verge. These mass are usually localized, and they are erythematous, they are indurated, and patient does not usually have fever and leukocytosis. The most patient can go for ED incision and drainage, but I think I have not seen ED doctors doing incision and drainage in the ED, but I think it should be done by surgeons. if they are willing to do. Another one is rectal abscess. It is just outside external anal sphincter that we can see just outside external anal sphincter. We can see intersphincter rectal abscess. Here the patient complains of buttock pain, and there are indurated mass in the different parts of buttock. However, if the abscess is high above, indurated mass may not be seen. Here the patient may have fever and leukocytosis, and Another one is sphincteric abscess. These abscess lies lower down the rectum, and lower down the rectum. They can also have indurated mass in the around the rectal area. On a PR examination, fever and leukocytosis may present in this patient, this type of patient as well. Supralevator abscess, these are they are above the levator anal muscle, and the patient complains of fullness of perianal region and buttock, and also complains on the same area. These patients do present with fever and leukocytosis. The next one is postnatal abscess. They are deep to the external sphincter and below the levator anal muscle. And they all present with rectal fullness, and pain is referring to the coccyx region. All of this patient, these abscesses need surgical referral, because this patient needs incision and drainage irrespective of the position. Probably if the patient tolerates, they can do under local anesthesia, but most of the patient go under general anesthesia, and drainage, incision and drainage will happen in theater basically. Proctalgia. My next topic is proctalgia. Anyone has any questions up till here basically?
Yeah, I think a very good presentation. I think the rectal bleed can be painless, can be painful.
Yeah.
So then we will differentiate different causes, basically in the two arms, and the perianal swelling, painful swelling. Yeah, you're right. I agree with you, because I've been working in surgery. It's always a problem. But the two abscesses, supralevator and the intersphincteric abscesses, they are nasty because they create what they call perianal fistulas.
Yeah.
And cure of perianal fistula is a really difficult, because you repair, then it happens once, and it's really, so the surgeon has to be very careful. Pylonidal sinus, it's a you mentioned postnatal, is it? Postnatal.
Yeah, postnatal. That's what the postnatal one.
Postnatal might be pylonidal sinus. Yeah, you're right. I mean, it's normally it's like occupational and more common in. More common in men, and
So, men.
Yeah. So I think the hair buried in and they're a little bit dimple, and it keep on burying, cause abscess. Very painful condition. All these I absolutely agree. So we should not mess with them, especially the risk of creating a fistula by the delayed referral. So these patients need to be referred to the surgeon ASP.
Proctalgia. Proctalgia is basically, thank you, Jay, for all the information. Basically, proctalgia is anorectal pain. The most important cause of proctalgia are all the pains that are above, but apart from that, we can patient with proctalgia also have some other causes. They are levator anal syndrome and proctalgia fugax, and other cause of anorectal pain are due to tumors, cauda equina, endometriosis. And I'll briefly talk about levator ani syndrome. Here the pain is due to tenderness or the spasm of the levator ani muscle. Here the patient present with dull pressure in the sacrococcygeal area, and the precipitating factor would be prolonged sitting, passing heart phases. Again, here the for rectal examination, on examination, there is tenderness in the levator ani muscle, and the treatment would be seize bath, massage of the levator ani muscle, and muscle relaxant. Next one, proctalgia figures. As this patient, as this figure says that the patient will have back pain around the rectal area. It is the proctalgia figures is intensely spasm pain in the rectal area, and it can starts very abruptly and can last up to 30 minutes, and the pain often radiates to the coccyx and towards the perianal region. Here, the treatment includes bowel cleansing regimen, upward manual pressure of the anus, diazepam, and topical nitrates. Another one is rectal prolapse. The rectal prolapse is also known as precedentia. Prolapse means descent of the structure from its normal position is known as prolapse. If the rectum descends from its normal position, that's called rectal prolapse. It mostly occurs in extremes of age, and it is also common in women who have UV prolapse. Basically, in the patient with UV prolapse, the structure within the pelvis are lax, and they tend to it is associated with rectal prolapse as well. Here, types of rectal prolapse, it is broadly classified into two types, incomplete rectal prolapse and complete rectal prolapse. Incomplete rectal prolapse, here the mucosa of the rectum prolapse from its normal position, and incomplete rectal prolapse, all three layers of gut, all the layers of gut are prolapsed from its normal position. Here the patient present with mass in the perianal region on coughing, sneezing, or defecation, and the patient also complains of fecal incontinence, foul odor, or bloody or mucous discharge. Treatment depends upon reducibility of the rectal prolapse. If the prolapse is reducible, the patient himself tries to reduce prolapse to his normal position. If he cannot, in the ED doctor can also try to manipulate and reposition the rectal prolapse in ED. I think Sundar recently did reposition of the rectal prolapse in ED. Here the patient are kept in a prone position, and the prolapse portion are covered with soaked hyperosmolar solution like sorbitol. The sorbitol is drains out the absorbs all the fluid or water from the prolapse portion that will cause shrink in the size of prolapse, and also the after this, if the ED doctors should try to put back the rectal prolapse into in normal position by pressing into the rectal wall. But in doing so, we should be very careful that we should not poke tissue. We should not poke tissue, but as it there is chance of perforation of the tissue, and if there is irreducible the prolapse, that should be referred to surgeon. However, for both reducible and irreducible prolapse, surgical referral is mandatory. And following reduction of rectal prolapse, we can also give wash treatment for the patient to alleviate pain and make the patient more comfortable. Management of all PR bleeding depends upon hemodynamic status of the patient. If the patient is unstable and then we need to open 2 large bore cannula, give IV fluids, and reassess patients after fluid. Again, send bloods for full blood count, and also blood group and save in case the patient is bleeding. Patient bleeds more, and if blood is necessary, then we can be prepared for that one as well. Most of the patient may complain of may have features of sepsis. For those patients, we need to give prophylactic antibiotics as well. And again, input and output chart should be maintained, and categorize the patient to see the urine output in a patient if the patient is hemodynamically unstable. And also I have not included in this one is like we have to give the oxygen for the patient, any patient who are hemodynamically unstable. And for hemodynamically stable patient, treatment are done as I have discussed earlier in each of the conditions, like for hemorrhoids, medical management, and if not surgical management like hemorrhoidectomy. For fistula, again, wash regimen, and if chronic one, again, nitroglycerin and nifedipine, again, definitive management. And for abscess, refer to the surgeons for incision and drainage. And for rectal prolapse, if you try to reduce the patient in the ED if we can, but if it is irreducible, then we have to refer this patient to the surgeons. But however, both reducible and irreducible rectal prolapse need to be seen by the surgeons. These are my references. I basically prepared this slides from HIEM Learning and Rogers.
I think nowadays we have a facility to refer to the ESAC clinic. All sort of prolapse, rectal prolapse, whether when we reduce and discharge also, I would suggest that we should refer to the ESAC clinic, either to be seen the same day or the next day. So of course, if it can't reduce, then it need acute admission to the surgical ward. But the other prolapse is rated as, as you mentioned, UV prolapse, uterovaginal prolapse.
Yeah.
That's again, these are difficult situations to convince the admitting the people to admit them, especially with the gynae, because the gynae will always say, no, just put it back and send home, and then we could, because there is no clinic, acute heart clinic, which we are accessed. I think it will change with the introduction of SDAC. I don't know when that will be coming in, because the concept of SDAC with the trust is that they will centralize all the heart referral from the ED or the GP to that area where different specialty will be sitting, and they will be managing these patients. I think it will get a bit easy for us. But my point with the management in the CHIE is that so ED should have a presentation on SDAC clinic as well, because so we could do a lot of goodness if one of us will be sitting in the SDAC clinic. I don't know how they will work on it. So I think the things are going to get better and better in our trust. A very good, excellent presentation. Yeah.
So thank you, Suchit Dai, for a brilliant presentation. This is the third time I'm attending this anal pain and rectal bleeding. First was in January 2021, and second one is March 2021, and third one is today. So each time I learned something new, this like anal pain and rectal bleeding. So what I have taught, like Professor Subir said, in the UK, your face and your body is equal. So don't discriminate your someone butts.
I I think the other thing in ED management, the PR bleeding is, of course, we look patient as a whole. If patient is bleeding, unstable, low HB, so then clearly these patients are unwell and need further. But if the patient are well, young age, and the history is that they saw commode with fresh red blood after having a large purgation or constipated stool defecation, and you do PR examination and you see some sort of perianal tag or some fullness into the anal area, and there's no blood stain onto the finger stall. So these patients can safely be referred to the ESAC clinic. They probably don't need an acute admission. But if there's a blood on the finger stall and you are suspecting it might well be, or you are suspecting it might well be some sort of colitis, IBD they call it, inflammatory bowel disease. So I think these patients need some sort of acute referral, either to the surgery, and if there's IBD, most likely to the gastroenterology, to the medical people. I think a PR examination is very important in these sort of situations. Of course, along with that, you see the general patient as well and the blood test as well. And the other thing, other improvement, which I think is recently we are doing more and more, which is very good, really. I mean, doctors used to do it, but doing at a nursing level, at triage level, I think it's a most welcome change to me, doing VBG. I mean, really, it's really a game changer. Yeah, please do look at the patient notes, people who come with the sort of problem. So VBG as well, like, acute abdomen or PR bleeding, because you can see a lot of information just like there, you can see HB, you can see lactates, you can see potassium, you can see bicarb, you can see glucose. I think, certainly I'm in habit of looking at the notes, especially the VBG and these sort of ECG, these sort of stuff. So don't ignore them little tests. Urine check, I mean, they don't do anymore, is it? Because they say, no, above 65, urine check is no good. But I think urine check is a quite good indication, indirect indication of the vital sign, vital organ, which is the kidney. I think the urine check is also important. To me, it should be included in the triage. If the people can pass urine, or at least it can be requested at a triage level, so it can be done later on. So these are little things which we look at, and then we don't miss stuff. So I think just be particular attention on these little tests as well in the patient notes.
Well done, Suchit. Fantastic, very brilliant presentation. I totally enjoyed that.
Yeah, brilliant. Yeah.
And
as Prakash was saying, yeah, presentation, when you make presentation, spend a bit of time, just research. I mean, for instance, if you are writing something or reading something and some term comes into the reading and we can't understand, I normally have my iPhone with me and the iPad and everything. And just go on the iPhone and, type that term on my iPhone and go there and you can read about that. You see what I mean? So one thing lead to another thing, and people get more information in preparing these sort of slides and presentation.
I just wanted to, can you hear me?
Yeah, we could. Yeah, we can.
Yeah, that's it. I've worked on both sides of rectal bleeding. So as a surgical SHO, I used to see what used to happen when someone came with rectal bleeding. So they would actually come onto the ward. During the ward round, this patient came with a PR bleed, which was confirmed by digital rectal examination. So what you do is you would say on the ward, your count starts from there. If they have 1, 2, 3 more episodes within 12 hours of that admission process, you are going to order an angiogram, which is going to point at the bleeding point, where the surgical management might be embolization or any other procedure that will actually stem the bleeding. So it's when the surgeons actually take over, they will actually start thinking about, how they're going to deal with the bleed. So it will be based on further episodes of bleeding and so forth. From our A&E point of view, I think the whole thing is very simple. So someone comes with rectal bleeding that you have not seen yourself, it's on their account, but you can't dismiss it and say, well, I don't think it's true. At that time, you start making contact with the surgeons. If you do the digital rectal examination and you confirm it, you know that that's a obvious admission process. If you don't see the rectal bleeding, the surgeons also are also quite amicable in saying this patient would go to ASAC. Now, from what Mr. J said about the new structure, which is going to have all the surgical specialties amalgamated into one. Did you say that one?
No, it's
Would that have
ASDEC. It's ASDEC is it. So ASDEC will be like, the idea is that it will be, all the heart clinic should be working together. So for instance, some medical patient, which is, like acute ambulatory care, where they can discharge like a same day. And ESAC patient where like, this PR bleeding where people have blood, but now they're stable. You can't see any PR bleeding. You suspect it might well be hemorrhoids. So these patients can go there. And I do the gynae patient, which, like PV bleed, postmenopausal, menopausal, they are not pregnant, they have no ectopic pregnancy, nothing like that. So they are stable. So they can go there as well to be followed up. I think that's the concept of SDEC is coming out. I think I must make a point for the rectal pain. Always ask, have you have some sort of treatment in the hemorrhoid? Because, bacterial line, which was mentioned by Suchit, bacterial line, when you put this proctoscope, it's very easy to see because the color changes from there. When the rubber band ligate the hemorrhoids, if the surgeon take the bacterial line in, it's very painful. So always ask, have you have some sort of surgery done recently or rubber banding as well? Because people have sued the surgeon for this as a negligence, and people got money, like thousands of pounds. Because they band the bacterial line inside, and it's very painful as well because there's a nerve ending there. So I think these are little practice. And what we used to do when I used to work in surgery, we used to put in a proctoscope and see the bacterial line. Certainly I have injected hemorrhoids as well. So back home we used to inject almond oil. And then we have a, in here we used to inject corrosive. I forgot the name of that. It's a long name. We used to inject that corrosive substance into that. But rubber band ligation is you see a clear demarcation of the line. Then you have a little bit swelling there. What Suchit was saying is anal bulb. So so you suck that part into that vacuum, and then you fire the ligase onto that. So if you take in the pectin line, and it's very painful. Oh, well done. Any other business for the day, or we let Dr. Boone go now?
And shall I stop recording? Okay, I'm going to stop recording.